Yes, I know you know about chickenpox, also called varicella, but actually, do you know varicella? I'm Dr. Abraham from ENT Dermatology, and then today we're going to look at the details of varicella. So, varicella is one of the viruses that belongs to the same family as the ones we've seen before, the herpes virus. So, it is the herpes, a human herpes virus number 3. So, this virus is the very, very naughty, and it is a very, very common virus. And I think if you're a medical practitioner, you've at least encountered one case of chickenpox, because it is one of the things that parents bring their children to hospital. And even parents know it actually. They know the chickenpox, how it looks like. But in this video, I want to look at the details and actually the medical significance of this very common viral infection that usually occur in children. So still, the family is the same. It is a herpesviridae family, and it's also a double-stranded enveloped linear gene A virus. And it causes what we call varicella, commonly known as chickenpox, and also causes the herpes-zoster, commonly known as shingles. So this virus is also one of the commonest. Yes, we've seen this group is actually common. It has a global distribution occurring across the globe. Everyone can get infected, and very common in children, whereby almost up to 90% of the cases of varicella are seen in children below the age of 10 years. And this is actually a good thing, because if you ever get varicella above 10 years of age, you present with a severe form of varicella, which can actually even lead to death. So the transmission is through the respiratory droplets and or direct contact with the lesions. If someone has the varicella, then maybe the child is in these schools, the kindergartens, boarding section, they're interacting together, and then one of them gets varicella. Through this contact, you can actually spread the condition. Usually, it can also occur most commonly for those who have winter. It loves the late winter period and then early spring. But in our seasons here, it can occur actually at any time, though commonly seen in the sunny times where you have everything hot, dust, and people coughing and what. So they usually present more commonly in the sunny seasons. So because of the current trend where that by WHO included varicella in one of the immunizable diseases, and that immunization has brought significant decline in the numbers of patients or children presenting with chickenpox. But over time, the prevalence has been going down because of immunization, but we have started to see a trend where more cases are being reported. And because of this, you realize that there's even a booster dose now for varicella to try and cap down this new growing trend. So the virus itself has an incubation period of about 10 to 21 days before the onset of symptoms. But before the symptoms or the rash appears, usually you can have fever, headache, malaise, joint pains, loss of appetite. Then after that, the rash will appear. So the rash in varicella is very, very typical because it develops in stages. Usually it can start with a maculopapular presentation, which later becomes vesicular. You get now vesicles, which rapidly rupture. Then you get crusting. And because of this, when you see the vesicles on the patient, actually they will appear with this description usually given in dermatology, like a dewdrop on a rose petal, or you can call it maybe a teardrop. You know, a teardrop, usually you have a drop of water like this, then lying maybe on a leaf. So this would be like the arrangement. So when you look at this, you know that in black skin, this may be a little bit hard for you to see, but in this picture here, you can see where I'm drawing, you can see that background erythema, then you have these vesicles. So that is like now the teardrop on on an erythematous base, or you can call it a dewdrop on a rose petal. And what you have to notice that in chickenpox, usually the lesions are at different stages of development. So you can see some of them still being mucous, others are being papules, others are vesicles, and others are crusting, just like in this picture. So you see here, now this is crusting. Now this one is a vesicle. Now this one is a papule. Now this one is still a macule. So the lesions are at different stages of development. And varicella or chickenpox can complicate with bacterial infections. It can complicate with pneumonia, encephalitis. And what we have also to remember is that this condition is very, very contagious. And it is important for you to know which periods is it contagious. Usually, the child is very infectious first 5 days before the rash comes. So even before you see any clinical presentation, the child is already spreading the virus. Then they will remain infectious up to about 2 to 5 days. Some literatures say up to 2 days after the rash has appeared. Other literatures say up to 5 days or until when you have all the rashes crusting. That's when the child stops being infectious. So that means that if you diagnose a child with chickenpox, it is paramount for you to initiate isolation, say that until when they're okay, and it prevents further spread of the disease. So the mortality is a little bit low in children, about 1.4 per 100,000 infections, but in adults it is very high, up to 30.9. So that's why I was telling you that if you get varicella when you're an adult, it is really not a nice process for you to get. So there's a syndrome we call Ray's syndrome. Usually Ray's syndrome is usually the syndrome that you get when you try to treat varicella wrongly. So you know, people who do self-medication, they usually have paracetamol at home, aspirin, metronidazole. So they usually actually just want to treat. But in this case, if a child has chickenpox, then you treat with aspirin, you're actually going to complicate the condition, because when you treat varicella with aspirin, you get this syndrome. The syndrome we call Ray's syndrome, and it is very, very serious, though rare, but it has been associated with vomiting, encephalitis, even hepatitis, and even someone has a risk of convulsion or even death. And usually the management is you stop the aspirin and then you do supportive care and allow the body to heal. So you see in this animation, as you can see, this child baby who is having this rash on them, which is varicella, and then the mother gave aspirin. So because of that, the child had a big spleen and had manifestation of involvement of the brain, which is encephalopathy. So this one, you need to remember it, that every time you are applying a patient, ask the history of medication they have given and identify if they're given anything, which is aspirin. So in terms of treatment, we usually treat it by supportive, and then you hydrate, and then you control the fevers with analgesics. But in case it's severe, you can give acyclovir, especially in the immune-compromised patients. And if you have bacterial infections, you can also manage them with antibiotics. Because of the itching that comes with the condition, we can give an antihistamine and then a soothing lotion, which is calamine, which is also drying because it has zinc oxide, which is a drying agent and also antipruritic properties. So you can do calamine, and then you do paracetamol or ibuprofen for the fevers. In this illustration here, we are showing you how to treat. So even at home, you can do the colloidal baths, you can do baking soda. This is usually soothing. You can do calamine lotion, then you keep monitoring the temperature. If the temperature is high, you can give non-steroidal drugs, and then you can also go for medication in case it is needed, but you can also give the antihistamine for the itch. So varicella can also complicate when it is transmitted from the mother to the child. So when this one occurs, it occurs by vertical transmission. So where the mother gives the child the varicella, especially if the mother contracts it during the period of giving birth or even before. So it is usually a very high risk, or you get severe complication if the mother suffers from varicella. within the first 20 weeks of pregnancy. So in that case, there are high possibilities or chances of getting the congenital varicella syndrome. And in this case, the child will present with the limb hypoplasia or limb defects. You can even get skin scarring, eye defects, and sinus abnormalities. So that's why you see this is on antenatal, mothers are screened for varicella and or immunize. They do the titers, if the titers are okay. And then you are in the preparation for getting pregnant, usually also vaccinate for varicella. So in this picture, you can see this child born to a mother who had varicella, and then you see this skin changes, the atrophy of the skin, or the one we call congenital absence of the skin, and the rest, and it was because of varicella. So in the neonatal varicella, this usually occurs if the mother gets the infection during the time of delivery, and usually it is very bad if the mother gets the infection just like 5 days before or 2 days after they have given birth to a child. Remember, I told you that the infective period is usually 5 days before the rash, or it remain infectious after about 2 to 5 days after the rash has appeared. And in this case, if a child gets this neonatal varicella, you'll have a high-grade fever, vesicular rash, third-day poor feeding. You can also end up with pneumonia, hepatitis, and then also encephalitis. And it is very fatal. And in most of the cases, up to 30%, children end up dying because of one, maybe delayed diagnosis of the condition, then two, maybe poor management and not knowing what to do. So in this case, you have to remember that even varicella, if the mother has varicella during that period, you have to attend to the child in the fastest way possible, and then you give IV acyclovir until when the child stabilizes. So you can also give immunoglobulin for exposed infants. So these ones are, although they're not really available, but if you're in better settings, you can also give IV immunoglobulin. So when you go to the vaccination, varicella is one of the vaccinated conditions, and in this case, we give a live attenuated vaccine, and it is usually administered in 2 doses. So depending on the country and the policy they are following, they give 2 doses, but the minimum separated by about 3 months, those are 90 days. And usually this vaccine is very effective in preventing the disease, being able to give you protection in about 90% of those that receive the vaccine. And what is important is that if you've ever received a vaccine for varicella and you want to confirm that you actually you have a working vaccine, then you have to do the titers. So there's what we call modified varicella-like syndrome, which usually occurs in the children that are vaccinated. It's like a mini varicella, like you get varicella but not a bad type. And it is usually very mild, and someone gets fewer lesions. According to literature, if you are to count the lesions in chickenpox, they're usually above 300. But in modified varicella-like syndrome, someone will have about 50 lesions or even fewer. And this one usually occurs in patients that either you have suffered from it before or you are vaccinated. And it usually lasts a little bit shorter with it being still less severe, but you can actually transfer or transmit it to other patients. Then, when we go to varicella in the immunocompromised patients, in this case, this disease is very, very bad and it will complicate. It can give you a prolonged rash, organ involvement, liver, even the brain. And here the mortality rate is very, very high. And immediately you have to give IV acyclovir, isolate the patient and manage them accordingly. So what are the complications of varicella? This little man is wondering. So one, you can get secondary bacterial infections, which are usually responsible for even the scarring that we see in varicella. Then you can get a pneumonia, that is when you involve the lungs. You can get cerebellar ataxia or encephalitis. And some patients can also have myocarditis, hepatitis, thrombocytopenia, Ray's syndrome. We've seen Ray's syndrome if you give aspirin or even papilla fulminans and the rest. So when you have now this varicella, we learned that the viruses in this group, all of them establish latency. So even for varicella, after you've been infected, the virus will be taken up slowly into your ganglion, right? So when it reaches there, it will sleep until when your immunity is down, then it should be reactivated. Then it gives you another disease in this case. And this is what we call the shingles. And in this case, you have reactivation of the latent varicella-zoster virus. And usually the risk factor is age. We've seen this being activated in the elderly patients because of decrease in their immunity, or in the immune suppressed patients, especially those on chemotherapy, those who had transplant and they are on chronic suppression, and those living with HIV. And the symptoms, usually someone gets pain and a unilateral vesicular rash. Usually this one now follows the nerve distribution, what we call the dermatomes. And one of the complications is what we call postherpetic neuralgia, which is pain, and it persists even after the rash has gone. So this pain has also been classified into either acute if it occurs in less than 30 days, subacute, it's between 30 to 30 to 120 days, or chronic if it is above 120 days, those are 3 months. So usually in terms of prevention, there's this vaccine, the shingles vaccine that has been approved to give to the elderly patients before they actually get the shingles, and it is a little bit effective. So in terms of the distribution, how common is this shingles? Commonly, 55% usually occur in the thoracic region, affecting the thoracic nerves. Then cervical 20%, lumbar 15%, and then sacral only contributes a little bit over 5%. So there's a term we call disseminated herpes zoster. So usually we know herpes zoster follows a particular dermatome. So if the nerve maybe supplies this area that have drawn, so that is its dermatome. So if you have rashes of varicella occurring outside one dermatome, then it becomes disseminated herpes zoster. So according to literature, if you have more than 20 lesions, for example, that is 1, that is 19, that is 20. If you have more than 20 lesions occurring outside the dermatome, then you end up with what we call disseminated herpes zoster, and usually that one occurs in an immune suppressed patient. So there's another term we call the ophthalmic zoster or herpes zoster ophthalmicus. In this case, if you have the involvement of the ophthalmic branch of the trigeminal nerve, the fifth cranial nerve, then we call that herpes zoster. So I was telling people that this is one of the devastating diseases. Now in this picture, I think you can take a look. You know, it is now following the dermatome here, and on one side of the face, but now we are having involvement of the eye. And in this case, the patient ended up losing actually their eye, ending up with blindness in this eye because of just zoster. So it is a very serious condition that you need to manage in time, especially if you have involvement on the, or if you have involvement of the vital parts of the body, especially the eye, the ear, the tongue, the nose, or even if you have wherever it is, you have to manage it in time, because we've seen even other side effects, like if it is in the sacral area, you can end up with what we call the motor neuropathy that can give you urinary retention and the rest. So you can end up with even urinary incontinence because of zoster. So we need to manage it in time. So complications like keratitis, loss of vision, and a rash in that dermatome. And in this case, you need urgent evaluation every time you see this zoster or near the eye. Rush to ophthalmology so that they also manage in the due time. So there's a special sign in zoster we call Hutchinson's sign, and in this case, if you see rashes involving the tip of the nose, like in this case it is not, but in this case you see this tip of the nose being involved, and the sides of the nose, like here and here, then that is what we call the Hutchinson sign. And that one actually shows that the virus has involved the external division of the nasociliary branch. And in that case, you need also to be very serious, because this one shows that you can have you can have a lot of complications. So you remember now you have the eye, you have the ear, and then also the nasociliary branch. So you can end up with ear loss, blindness, and all this disfigurement in one patient. So other complications of zoster, we have what we call the motor nerve neuropathy. These ones are a little bit rare, but they can occur where the virus affects the motor nerves, leading to weakness or even paralysis. It occurs like in 3% of the patients with zoster, but uncommon usually involves the face, and someone can present with Bell's palsy, which we are all familiar with. And in this case, may need rehabilitation, and then you have to give antiviral drugs. And in case you have inflammation of the nerves, you are supposed to give the steroid, because in the pathogenesis, in the first steps of inflammation, you have neuritis, which is inflammation of the nerve, which also contributes to the damage of these nerves. So you have to give a steroid right away. So there's also what we call the postherpetic pseudotumor. In this case, if you affect the motor nerves supplying a particular bulk of muscles, especially if you have it's affecting the thoracic nerves, which supply the abdominal wall, then that wall will become weak, and then the contents of the abdominal wall can protrude out, giving what we call a pseudotumor. And it has also been seen because of zoster, commonly affecting the thoracic nerves. So if it occurs in S2, S3, and S4, the sacral nerves, it can also cause urinary retention, bowel retention, and even erectile dysfunction. So varicella-zoster is not just varicella-zoster. It is a very serious disease that needs the attention it deserves. Still in management, you have to give anti-inflammatory drugs, steroids, and also antivirals. So we also have another syndrome we usually see in varicella-zoster. We call it the Ramsay-Hunt syndrome. And in this syndrome, it also has another name called herpes zoster oticus. In this case, you have the zoster affecting the facial nerve and together with the auditory nerve. So that means that in this case, the virus is affecting the geniculate ganglion. You know these nerves, all of them pass through they are given out from the geniculate ganglion. So if the virus affects this, so someone will end up with the severe pain in the ear, facial nerve paralysis, and then also vesicles on the external ear canal, because that's where these nerves supply. So at the end of it, or if you don't manage well, someone can end up with hearing loss and then also vertigo, as well as paralysis on the face. Still, in this case, if this gives steroids, high dose actually, even antiretroviral drug, and then you have to do rehabilitation to make sure that you minimize nerve damage. So even the cyclovir, you see in this case, we're giving high dose at 800 milligrams 5 times a day. And this is intended to make sure that at least we maximize the outcome, because you know the devastating effects that can come out of it. So remember, for the Ramsay-Hunt, we're affecting the geniculate nuclear ganglion, which supplies the organ of the facial nerve and then the auditory nerve. So in this case, remember that someone can end up with tinnitus because of damage the nerve, the auditory nerve, and facial paralysis, which looks like the Bell's palsy. Okay. Then we have the zoster-associated pain syndromes, that is the postherpetic neuralgia, and this is the pain that persists even after the shingles or the rash has gone. So this pain can stay with these patients up to their age, until when they go to the grave, actually, because at the clinic you have patients whereby we've managed this condition for over 5 years, but they keep coming and we keep trying different treatment modalities, and then we just improve their quality of life, but the pain can stay there. And that is the classification that I talked about. It can be acute for 1 month, subacute 1 to 3 months, and then chronic more than 3 months. Still in the management, we do pain management, we actually end up using antidepressants and convulsants and topical agents. You can give vitamin C supplementation or botulinum injection so that you actually completely destroy these nerves that are causing that pain. So the mechanism of how this postherpetic neuralgia comes about, it has been stipulated to be two mechanisms that are being hypothesized. The first one is sensitization, whereby when you have this acute viral infection in this area, the nerve fibers that supply this area, for example, if that is the nerve fibers, nerve fiber that is going away, now this one is coming. So the one that is taking away sensory information is what we call the afferent, isn't it? So then the one that brings back is the efferent. So this one takes information, this one brings back information. So when you have this acute infection of the virus, there's this inflammation and destruction of the nerve, and in that process, the injury results into proliferation of these nerves and increased sensitivity or sensitization of these nerves, meaning that they take a lot of information back, right? So because of that sensitization, even a small pain is now amplified. Then it is because of that you have sensitization at the periphery here, where the rash is near the skin. But then when you have a lot of signals going to the spinal cord, you can also have a increase of cells of neurons that respond to this pain in the central nervous system. So you can also end up with central nervous system sensitization. So every time this virus tries to get reactivated, the burning and tingling that comes as prodrome is over-amplified in these patients because of the peripheral and central nervous system sensitization. Then the second mechanism is what we call the deafferentiation, that one. So in this case, these are the nerve fibers that are supposed to bring back information from the brain back to the effector muscles. So what happens is that this damage that you have here, the damage that you have here causes destruction of these nerves, meaning that you end up with something similar to what we call a phantom limb. I think if you know phantom limb, you know that if you cut off one limb, that those nerves that are there but are not taking away or bringing back information, they end up giving them that pseudo pain, that as if that leg that was cut off is still there. So the same thing that is also thought about here, that you have the afferentation of these nerves. Okay, so in summary, if I'm to summarize varicella is a herpes virus that causes chickenpox and shingles, especially in the immunocompromised elderly and those on chemotherapy. And it is very key to give vaccination for children to prevent this. We give a live attenuated vaccine. Then we also have a vaccine for the elderly. Before they get any episode, they can get that vaccine to prevent them from actually getting the postherpetic neuralgia. Then what we have to note is that it can be very devastating, especially those that are immune compromised. We have different types of the zoster. We call it disseminated if someone gets over 20 lesions outside the dermatome. And we can have it affecting the eye, that is herpes zoster ophthalmicus. We can have it causing the Ramsay-Hunt syndrome when it affects the nerve fibers that come out of the geniculate ganglion. Thank you very much for listening in. I'm Dr. Abraham from the Anti-Dermatology Specialist. See you in the next video.